Chronic liver damage can result in cirrhosis, which leads to portal hypertension. This induces the development of a hyperdynamic circulation, characterized by increased cardiac output and heart rate. It also drives peripheral arterial vasodilation, which decreases systemic vascular resistance, resulting in a decreased mean arterial pressure. With worsening of the underlying liver disease, increased cardiac output cannot compensate for these vascular changes, and homeostatic mechanisms controlling blood pressure and fluid retention become activated. These mechanisms include the renin-angiotensin-aldosterone system, the sympathetic nervous system, and the release of arginine vasopressin. As a consequence, increased sodium and water reabsorption contribute to ascites formation. Concurrently, intrarenal vasoconstriction and hypoperfusion impair kidney function, leading to hepatorenal syndrome with acute kidney injury, HRS-AKI. Kidney injury may initially be reversible, but can result in permanent damage, the need for dialysis, and increased morbidity and mortality. Vasoconstrictive drugs can increase mean arterial pressures to levels that will increase systemic pressures and restore renal blood flow. One approach involves the use of synthetic vasopressin analogs, which induce vasoconstriction by stimulating V1a receptors on vascular smooth muscle. Existing vasopressin agonists are non-selective at therapeutic human doses. A lack of selectivity for V1a receptors can result in activation of V2 receptors in renal collecting ducts, increasing fluid retention and potentially contributing to respiratory failure. Full V1a receptor agonists have a steep dose-response curve and may potentially induce severe vasoconstriction and tissue hypoperfusion at therapeutic doses. Hence, the use of full V1a agonists for the treatment of HRS-AKI may require careful monitoring or titration to prevent excessive vasoconstriction, which can lead to tissue hypoxia and ischemia. OCE-205, a novel vasoconstrictor, uniquely has two domains, a cyclic V1a receptor agonist and a linear V1a antagonist. In preclinical studies, OCE-205 demonstrated activity only at the V1a receptor with no V2 receptor activity at therapeutic concentrations. When OCE-205 binds to the V1a receptor through its agonist domain, the receptor is stimulated. When OCE-205 binds to V1a through its antagonist domain, receptor activation is blocked. OCE-205 is designed to activate a proportion of V1a receptors to achieve a desirable degree of vasoconstriction. Meanwhile, the V1a antagonist activity effectively limits the overall proportion of receptors available for agonist stimulation. This mixed agonist-antagonist approach may allow for a predictable capped maximal effect compared to existing agents. In addition, the absence of V2 agonism may limit the potential side effects of fluid retention and overload. Treatment with OCE-205 may achieve the desired therapeutic effects of arterial vasoconstriction, reduced portal pressure, and increased blood flow to the kidneys. This unique mechanism has the potential to lead to significant clinical improvements in patients with complications associated with cirrhosis, such as HRS, AKI, and ascites.